Hey, hi, this is Dr. Yogashree Sonawane, and today I'm going to present my research topic on concurrent myiasis and mucormycosis in the orofacial region. So, what is myiasis? Anyone have heard about maggots? So, maggots are the parasites that grow within the host organism. They feed on dead as well as the living tissue. And myiasis is this parasitic infection of this maggot, which is caused by the fly larvae. Okay. Mucormycosis is a fungal infection, which is caused by Mucorales. Now, this co-infection is most common in comorbid and immunocompromised patients, such as those suffering from diabetes, hypertension, leukemia, COVID, etc. So, the study highlights the synergistic infection of myiasis and mucormycosis in the orofacial region. So, what are we going to study? We are going to study the clinical manifestation of this co-infection along with the associated diseases, the risk factors, and the treatment modalities that are adopted. So, for this study, a literature review was conducted to include all the articles which had the case histories of co-infection of myiasis and mucormycosis. So this study is still under consideration, and today I'm going to represent a snapshot of the study. So we are going to see, we have 30 patients' case histories which were having a co-infection of maggots and mucormycosis, out of which maximum were oral, that is 13 people. Then seven were multiple as in more than two sites were involved. So it was rhinomaxillary cerebral or rhinomaxillary orbital. So more than two sites were involved, then that becomes the multiple. There was one case of sinonasal, one of maxillary, two of orbital, and six of nasal. Only one component nasal. Okay. For gender, we saw that female were 47% and male were affected for 53%. For age, maximum people, that is 16, were 50 and above, 51 and above. Less than 20, only 4 people. And in between, in the range, they were the mid age, they were widespread. So 21 to 25, we had one. There was no patient from 26 to 30 that we got in our data as of now. 31 to 35 was two, 36 to 40 was two, and 41 to 45 was one. About the clinical manifestation, theory suggests that sneezing and lacrimation has been common, but we also saw, other than that, we saw pain, which is a common clinical manifestation, swelling, discoloration, halitosis, and very important, oroantral or oronasal communication, fistula that was seen, and any kind of a discharge. So either it was a purulent discharge, either it was a blood discharge. So any kind of a discharge. So these are the numbers. I have not given the percentage as, like I said, it's just a snapshot. We are just presenting on the 30 case histories that we have studied. I would like to highlight that there were other symptoms which are bodily manifestations which were commonly seen. For example, drooping of eyelids, ptosis, absence of perception of eye, that is affecting rod cells, vision loss, cellulitis, headache. Okay? And there was one case in which we saw three infections, um, that was documented. So first was mucormycosis, myiasis, and actinomycosis. So that patient also had an actinomycosis infection, and we saw that actinomycotic osteomyelitis that was documented in the case paper. So that was one case paper that we came into consideration. About the associated medical illness, we have seen this co-infection has been associated with some of the other comorbid medical illness. So in that, diabetes was the number one illness which was seen, 33%. Apart from that, mentally challenged people had more predisposition, and especially those with cerebral palsy were documented in most of the articles. That is 23%. Other thing I would like to highlight is these patients, about 26% of the cases had a history of either a fall or a tooth extraction or a major surgery which they had gone. So now why this predisposition is there? What is the pathophysiology that we will consider in the discussion part? But this has been a striking revelation that whenever there is an unhealed traumatic wound or unhealed socket, they are there are more chances of getting a co-infections of mucormycosis and myiasis. Other small features that I want to highlight that out of 30, only 9 cases, the types of maggot were identified, out of which 5 were Musa domesticus and 4 were Baesiana. Other cases, the sample was not sent, or the species was not identified, or the resources were not available for testing. Most of the cases were treated with the of infestation were treated with the turpentine oil. However, many articles have documented the use of hydrogen peroxide, betadine, 0.12% chlorhexidine. Okay, so they have been proven to be equally efficient with or without turpentine oil. Okay, for surgical, the wound, um, many a times it was, yeah, it was debrided. It was given salt douching. It was kept open for the wound healing to happen. And many a times there used to be externation. Externation, that is, a part was removed. So either maxillectomy was done and followed with the prosthetic rehabilitation, or either externation of eye was done and followed with the eye prosthesis. So many a times the complete part has to be removed, because reason is because the parasite also works on a dead necrotic tissue. It also can strive on dead necrotic tissue. So that is why the entire cleaning did not help. You had to remove the part of the affected area. Medicines, amphotericin B, but as we know, chances of nephrotoxicity are there. So most of the time it was limited, the use was limited, and there were other medications that were used like ivermectin, doxycycline, amox, ceftazone, etc. Now, like I said, the discussion. Now, this is again a snapshot of a previous article from one of my articles that I have written. Um, in which we have tried to find out a probable pathophysiology. So, infection spread through airborne routes. Okay, and when a wound is open and it is unhealed, it has more chances of getting infected. That uh, is a entry point to all the parasites and the fungal infections. Other than that, there is less blood supply. So the chances of being necrotic, um, getting affected, the normal tissue getting affected and having a widespread damage is high. Because of these two, three issues, we have seen that we have to be very cautious when we have done an extraction or done a surgery of a patient with comorbid illness. So, what we have to look for is, first you check for a patient's medical history, if he has undergone any medical major surgery or even the basic tooth extraction. And you do a post-operative patient follow-up. You look for extraction sockets. You look if the sockets are getting healed. You look if the wound is getting healed. Because these sockets or this unhealed wound, they serve as an entry point. And always prevention is better than cure. So if we can prevent it through effective follow-up, then we don't need to uh, take efforts for curing the patient and then all those things, because it's very damaging. You sometimes it doesn't get clear. The infection can sometimes take months to go, and sometimes even 3 days. So it all depends on the immunity factor of the patient. So as I said, prevention is always better. Next, maintaining a good oral hygiene is an important criteria for better and faster healing. So any patient, if he is suffering from such a disease, first of all, its immune is compromised, but he has to maintain good oral hygiene. So if he could maintain good oral hygiene, that can also be a helpful factor. And last but not the least, getting in control of the disease, the underlying associated disease, like we saw the diabetes, hypertension, coronary heart disease. So getting those diseases in control can also help to cure the co-infection of maggots and mucormycosis. So these are few of the takeaway points that I have enlisted. So I'll just stop this here. It was just an overview, and I thank you for joining. Thank you very much.